Good afternoon, everybody, and welcome to the American Heart Association's Western States Get With the Guidelines Stroke Office Hour. This event is being recorded and will be housed on the American Heart Association's website. Any materials or resources shared from today's office hour will also be made available to you after the presentation. Everyone has been muted. However, please feel free to ask questions via the chat box. We will start today with some updates and then our pre-submitted questions. After, we will open it up to the chat box questions. If you have experienced any difficulties, most issues can be resolved by refreshing your browser. My name is Ron Loomis. I am one of the Senior Regional Directors for our Quality and Systems Improvement Team for the American Heart Association in the Western States. Joining me today is Misty Thompson. Misty is the Stroke Program Director for the Carondelet Health Network in Tucson, Arizona. She is a two-time alum of the University of Arizona, earning a BS in Family Studies and a BSN in Nursing, and is currently pursuing her MSN FNP. Misty is a critical care nurse specialized in neurocritical care and remains active at the bedside in the neuro ICU at the Carondelet Neurological Institute. Misty is an active member of the U.S. Army Nurse Corps, where she is a captain in the Army Reserves and serves as a critical care nurse. She is a nurse volunteer for an international care team where she volunteers for the Flying Samaritans. She is a volunteer for the American Heart Association, American Stroke Association, where she currently is a member of the Western States Stroke Committee. Misty also represents Southern Arizona with the Arizona Department of Health, Heart Disease and Stroke Work Group. Also joining is Jason Wolchuk. Jason is Stroke Data Manager for the American Heart Association and manager of the Get With the Guidelines Stroke Registry. Prior to the AHA, Jason was the stroke coordinator for the state of South Carolina Bureau of EMS and pre-hospital quality improvement director for the largest EMS system in the state, Greenville County EMS. Today's call topics will include the 2021 award metrics for the 2020 stroke data that is currently being entered, upcoming Get With the Guidelines stroke patient management tool updates, target type 2 diabetes, some pre-submitted questions, and then a demo of our upcoming EMS picker that many of you may have heard about at the recent International Stroke Conference. And then after that, as time permits, we'll open up for questions and answers. So with the new criteria, as of January 1st this year, the American Heart Association has made an update to our achievement and quality measures. We'll be moving discharged on a statin and IV TPA arrive by 2, treat by 3 hours to reporting measures, and we'll be moving our IV TPA arrive by 3.5 hours, treat by 4.5 hours, and intensive statin therapy from our quality measures to our achievement measures. These two measures will need to meet the 85% or greater achievement requirement to be eligible for awards in 2021. That also means hospitals that would like to achieve the Plus Award will need to achieve 75% on 5 of the 6 quality measures that remain. Patient management tool reports will be updated to align with these changes later this year. The future updates that are coming out later this summer will affect alteplase contraindications, diabetes cardioprotective measures, the target stroke advanced therapy, and there will also be some updates to our coding instructions. So the first one, as many of you are aware, in the latter part of 2019, the rapid or early improvement was moved from W6 under relative exclusion criteria down to other reasons, hospital-related factors. When the update happened, it may have inadvertently changed your 2019 data adherence to your IV TPA for Arrive by 2, Treat by 3 hours, and or your IV Arrive by 3.5 hours, Treat by 4.5 hour measures. The upcoming update will correct this error for the 2019 data. However, as of January 1 of 2020, rapid or early improvement is no longer a valid relative exclusion and therefore will not exclude patients from these measures. What's being corrected is the report. So when you run the report, if you're looking retrospectively at 2019, it will be reflect correctly that those patients would still be excluded. Our next update is our diabetes cardioprotective measure. If you selected DPP-4 inhibitor, the following element, was there a documented reason for not prescribing a medication with proven CVD benefits is grayed out, excuse me, and does not allow you to select yes or no / no data. This will be corrected and will remain grayed out for it. This will be corrected, and when DPP-4 inhibitor is chosen, that next question would be then opened up for you to answer, was there a documented reason for not prescribing? It will remain grayed out for the GLP-1 and SGLT2 inhibitors moving forward. The next change is around our Target Stroke Honor Roll Advanced Therapy Report inclusion criteria. Currently, there's an error with the inclusion-exclusion criteria for door to start of device measures for the arrive within 6 hours and the arrive within 24 hours. Currently, the inclusion criteria is looking for both when was the patient last known well, or date and time of stroke symptoms response before calculating if the patient should be included. So though the instructions is saying or, unfortunately the algorithm chose it as an and. So if either one, date and time of last known well is blank, unknown, or only has a date and not a time, and the same thing for date, time of discovery of stroke symptoms, then currently the patients are being excluded. With the next update, which should be happening soon, it'll go back to the or. So if you have one or the other or both, then it will then move through the calculation. And if it's within the time frame, then it would be included in the measure. If it's outside of the time frame, then it would be excluded. The next one is a coding instruction update. We've heard from many of our customers that with the last update, when we changed the payment source to include more options, that there was not clear coding instructions on which one they should be choosing when abstracting. So with the update, one of the coding instructions that will be changed is it'll include a breakdown of what a Medicare Title 18 would be, Title 19, the Medicare private, the Medicaid private, etc. For those elements, here is a quick example of what that's going to look like, but they will give you examples moving forward. We're sorry about that inconvenience. We had lots of people that were confused by those changes. The next one is our Target Type 2 Diabetes Honor Roll. I wanted to go through this with everyone because we've had lots of people that have reached out regarding the new award opportunity, but not necessarily understanding what the inclusion criteria is or how to figure out where the missed opportunity is. So eligibility is get with the guidelines, heart failure or stroke. In this case, you have to be a silver award or higher for the module. Demonstrate at least 90% compliance for 12 consecutive months. So if this is your first year being a silver, it'd be this entire calendar year as well. But also looking at not only the composite of your achievement measures for your diabetic patients, but also there's 2 extra measures around diabetes treatment. So I will show you which elements those are as we drill down. But before we start, Get With The Guidelines is intended to be a quality improvement program. So for those of you that would like to drill down to review your missed opportunities, under Configure Measure Reports, you would then choose, under time period, look annually for 2019 to 2019. After that, under the Get With The Guidelines additional patient population measures, you're going to scroll down to the bottom. I believe it's the 5th one from the bottom of the list, is Overall Diabetes Cardiovascular Initiative Composite Score. You would change your format to patient records and then generate your report. Once generated, when it opens up, on the upper left-hand side, just above patient ID, you'll see the words Show Filters in bold blue writing. You want to click on that. Once you click on that, you then have options that'll have this little box that says either no filter, or whatever the options below it may be. So it can be blank, included, excluded. In this case, we want to click on the second box from the left, Included in Results. Once we do that, it will automatically shuffle and only show you those included patients. If you move to the right, one of the elements that is required is the diabetes treatment. Diabetes treatment and therapeutic lifestyle recommendations for patients with diabetes were not required fields earlier in the year. And so most sites, I won't say most, correction, a few sites were not answering those questions because they were not required fields. But you do have time to go back and make those adjustments if there's documentation that would also represent that for you. So over on the diabetes treatment, if you double click that on the diabetes treatment twice, you'll see the little down arrow. It will filter everyone with a yes to the very top and then the no's soon after. Those no's are the missed opportunities that what we're finding were not answered. They were just ignored and left blank. What we're finding, though, is a lot of those same no's for diabetes treatment are definitely the same no's for your therapeutic lifestyle recommendations for patients with diabetes. So while you're in the chart, it's just a little bit lower, but you're welcome to go down a few more spots and also address that question as well. If you want to start with the therapeutic lifestyle recommendations, again, if you double click on the blue lettering, it'll auto sort the yeses to the top, the no's to the bottom. I did not do it on this case, so it's only looking at the ones that were sorted by diabetes treatment. And at which time those no's again would be the ones you'd want to go back and look. What we've heard from our customers is most of the time the therapeutic lifestyle recommendations are already being included in your discharge instructions, but no one was abstracting to provide credit for doing that. So by going back in and correcting those, you have a good chance of adhering to that 90% and being able to achieve your award level. As I described, so the first one is the diabetes treatment. It's the percentage of diabetic patients or newly diagnosed diabetic patients receiving diabetes treatment in the form of glycemic control, diet or medication, or follow-up appointment for diabetes management scheduled at discharge. So this is on the discharge tab about halfway down. You'll see the anti-hyperglycemic medication. So if you're answering yes, no, and then the medication, and then the second part of that question would be the follow-up appointment. So as long as you've addressed either the prescribed or the follow-up appointment, you would be meeting that element. The second one, which is a little bit further down under other lifestyle interventions, you'll see TLC diet or equivalent. That is the therapeutic lifestyle changes. Again, if you're unsure of what that really means, you're welcome to double click on the other lifestyle interventions. It'll take you directly to our coding instructions and will allow you to drill down to see what the instructions are about how to answer that element correctly. So our first question is, are there any hospitals that are currently meeting the target stroke goal of 50% of endovascular patients having a door-to-device deployment time of 60 minutes in transfer patients or 90 minutes for non-transfer patients? So Misty, I'd like to have you be able to go ahead and come off mute and share because I know you're doing really well with this. Misty, you have to click on the red mic to unmute yourself on the computer if that's the one for your phone. I think Misty just got disconnected. You there, Misty? Well, as Misty works to come off mute, what I will share is under our targets, if you go into our heart.org/quality website, on the lower right-hand side, you'll see a box called Target Stroke. If you click on the Target Stroke when it opens up, you'll see a link that says Clinical Tools and Resources. I've also included the link here in the slides, which will be sent out after the program. But at that time, if you click on Clinical Tools and Resources, there's multiple tools there for you. The first of which I'd like to direct you to is the Target Stroke Phase 3 Door-to-Device Time Best Practice Strategies. There's 12 strategies that have been vetted through to show that they've been able to help improve adherence to that metric. So please take a look at those. There's also the 90-minute door-to-device goal time interval. We do have a timesheet that's there. Many of you might have remembered the old golden hour with the 60 minutes for TPA and working your way back. It was 45 minutes for results, 25 to be at CT, and 15 to be seen by a doctor. This is some best practices that we kind of figured out that if you kind of adhere to these times, that'll put you on track for your 90 minutes. Misty, were you able to come off mute? So sorry, I think she's having technical issues because we can't hear her. Hopefully she'll be able to join a little bit later or be able to figure out what the problem is with her mic. Her hospital has been doing quite well with their door to first pass, and she wanted to share how that's going. The next question we had, is there a simple statin medication guideline reference available? Clarifying the guidelines of who needs what dose. So in the coding instructions, there's a note saying you will be required to document a reason for non-treatment if the statin daily dose does not meet guideline recommended doses. Patients 75 or younger should receive the high intensity, and for those, unless it's contraindicated, or patients greater than 75 years should receive a moderate or high dose, and it refers you to Table 6. If you click on Table 6, it gives a list of all the meds. I just did a small screenshot of a few, but on the right-hand side, it says choose a moderate, or which one's a moderate, a high, low, or would not meet the requirement. The other part I'd recommend you to is on the very bottom. If you want more additional information, the 2018 American Heart Association, American College of Cardiologists, the AACVPR, the AAPA, and the ABC, and the ACPM, the ADA, the AGS, the APHA, the ASPC and the NLA and the PCNA guidelines all around the guidelines of management and of the blood cholesterol. And there's a hyperlink there for you as well when you get the slides.
Ron, are you able to hear me now?
Yes, Misty, here, let me back up and I'll go back to that slide. I'm glad you were able to
I'm so sorry. We're having some technical difficulty for sure. So I will go back to the question. I know you said it earlier. Are there any hospitals that are currently meeting the target stroke goal of 50% for endovascular patients having a door-to-device deployment of 60 minutes for direct transfer and 90 minutes for non-transfer patients? And I think the answer to that is yes. There are a handful of us. Not everyone is able to achieve that measure yet. And I say yet because it's definitely achievable. But I am with probably the majority of the callers on this that think it is impossible. And 2 years ago when we first started looking at all of these metrics and started really tracking aggressively our door-to-groin time, we thought there's no way when AHA and ASA came out with this device time to match what STEMI protocol is, really a balloon time of 90 minutes, I thought there's no way. And my providers, my physicians said there's no way. And so really we looked at our practices and really tore apart our times and said, where can we shave time? And so the first thing that you really have to do is you have to have a process in place for your brain attack. You have to have a notification that really notifies the entire team and gets everybody notified, the ED, the CT, the lab, and your neuro team, to make sure that everybody is responding to that patient with a sense of urgency. I know that in the latest guidelines, both the 2018 and the 2019, they talked about software that uses AI, such as Rapid. There's other programs out there. I would encourage you, if you don't have that, look into it or use something that helps you interpret those CTA and CTP quickly. I know sometimes you can have read times that are 25, 30 minutes, and that's going to really, really slow down your IR time. One of the other things that we've done and implemented over the last year is a one-call system for our IR team. So that means that when we activate, when our physician says, we need to get the IR team in here, we have a one activation system. So one page goes out to the team, and then they're activated. We don't have this, we have to call one person who has to call the next person, anything that might delay their response time. We also have a holding area right outside of CT where we are making that IR decision, and then we're prepping that patient. And so we have a medic or a second nurse that comes, and so we have two sets of hands. One hand is, one set of hands is monitoring TPA. If that patient was a TPA candidate, maybe they're monitoring the vital signs, the neuro assessment, reassessing those neural deficits, but then also we're preparing that patient for procedure. We found that even doing simple things like putting the patient in a gown and shaving that groin helps to shave time. What we really did was look at our STEMI process. We do really, really well in STEMIs, and we wanted to model that for our IR patients. And so we've done that. Now, as we've gotten better and better and better, so we started tracking our groin times a couple years ago, and of course they were up in the 140s, slowly came down, and then we were hitting sub-90s. And then American Heart, American Stroke came out and said, now we want device time. So we thought, well, gosh, now we've got to shave more time. And so we started to really, really look at our process. And I break apart each case, and I put it into boxes and look at where the time is. If our door-to-CT complete time is 15 minutes, and then our response time is 30 minutes, and then our decision time is 20 minutes, where is your time going? And one of the things that we found is that my physician teams don't use a standard dosing or concentration for heparin during their cases. So we looked at that, we talked about that, and we said, how can we get you guys on the same page? So really it's just looking at your process, looking at each different part of your process, and how can you streamline that? We sit down with our IR call team, and we have a monthly meeting, and we talk about what went well, what are your barriers to success. Some places are going to have a three-man call team versus a four-man call team. There's going to be pluses and minuses to both, and not either one is right or wrong, but that's the resources that you have. Another thing that we've put into place here is that our intensivists and neurointensivists respond down to the IR room or IR suite and help kind of provide standby just in case there's a blood pressure issue, a sedation issue, or anything that they can help so that my proceduralist can focus on the procedure and not, trying to manage this critical patient. The other thing that you can do is look at your documentation process. How convoluted or complicated are you making it for your team? And is this something that you can simplify? The other thing that you can do to really, really challenge your team is to set push goals. So we all know, and we're all very aware of what the national standard is, say the door to CT complete time of 25 minutes. We have an internal goal of 15 minutes. And what that does is just challenges my team to do it faster, do it quicker, do it more streamlined. And so when you start to set push goals, you'll start to achieve those push goals, and you'll start to see that your process is much quicker. Here at Coronel at St. Joseph's in Tucson, we also award. So when my teams meet those goals of door-to-device time of 60 minutes for a direct transfer or 90 minutes for a patient that comes in through EMS and goes through our brain attack process, we award a brain attack award. And so we want to recognize that. And it's amazing that positive feedback really, really gets that team investment, and they want those awards. And when I haven't, given that award out within a day of that brain attack, they're telling me, hey, where's my award? So it really, really just gets the team involved. And so if you refer back to slide 14, which Ron will send up slides out to you, you'll see that there is a couple of resources for you that'll help with just clinical resource tools. One of them is talks about goal to time interval goals. And what it is, it just kind of breaks it down. That's not a standard. That's just kind of a recommendation. Hey, this is what's worked. This is not mine. It's just one that's kind of put out there. And it's a great goal, because when you start to break down the time, that's how you can really make this goal achievable. And then the other resource is Stroke Phase 3 door-to-device best practice strategies, and that's also provided by the HA. That'll help you just kind of reach these goals. So I say yes, it is achievable, but it is not something that's going to happen overnight. This is something that we've been working on for several years, and so we're doing it, but it doesn't happen every case, every time. There are things that are going to be complicated. So thank you for your time, and I do apologize for the technical difficulty. Back to you, Ron.
Thank you, Misty. Thank you for sharing your process.
Absolutely.
So the next question that came in was, can you please speak on the topic of tenecteplase versus alteplase? So the first part is, in looking at the 2019 update guidelines, Class 1A evidence is in patients eligible for IV alteplase benefit of therapy is time dependent, and treatment should be initiated as quickly as possible. So our TPA is still listed as the Class 1A. As you drive down further or read further through the guidelines, tenecteplase, both times it's being mentioned, is may be reasonable to choose tenecteplase over IV alteplase in patients without contraindications for IV fibrinolysis who are eligible to undergo mechanical thrombectomy, and tenecteplase administered with their dose. Bolus has not been proven to be superior or non-inferior to alteplase, but might be considered as an alternative to alteplase. Both of those are Class 2B BR recommendations. And Jeannie, if you'd like to take yourself off mute, or Jason to chime in your thoughts, I'd appreciate it.
Hi, Ron. It's Jeannie. I'm off mute. So, we are going to, I think moving forward, we are going to start tracking thrombolysis, not just alteplase. So that will be coming forward in, it's going to take a couple months to get it incorporated into the PMT. But I want to point out a couple things here. There's not, these guidelines don't indicate that you should basically dispose of alteplase and start using tenecteplase. There are clinical trials ongoing with tenecteplase looking at dose, distinguishing best dose, and actually expanding the time window as well. I'm sorry, I have my post-ISC cold this year. I also want to point out that there the dosage issues. So be aware that the alteplase dose that is currently indicated for patients going on to mechanical thrombectomy is 0.25 milligrams per kilogram with a maximum dose of 25 milligrams versus what we see in minor neurological impairment. And I don't quote me, but I believe that clinical trial, when they talked about minor neurological impairment, it was a NIH stroke scale of 6 or lower. But the minor neurological impairment dose was 0.4 milligrams per kilogram single IV bolus. So be aware of the two different indications and the two different doses, and also that it's, we have heard from sites at various places across the country that they're going to do a total switch out of alteplase for tenecteplase, and that is not the the indication that is put forth in this guideline.
Thank you, Jeannie. I appreciate that.
I don't know if Jason has anything to add from a PMT standpoint. We've done some work around that.
Yeah, sure. I could talk briefly. As Jeannie described, with these guideline changes and a lot of the questions that are circulating around about it, the clinical work group here at the AHA that works on the stroke PMT and Get With the Guidelines program did decide to add data elements that will capture TNK, so tenecteplase. The measure logic and things won't change because the initial questions and date and time fields that are both for alteplase will just be converted over to thrombolytic administration date and time and whether they were given or not. So the measures will still be the same since it's still a time-sensitive intervention. They'll flow and be included. Obviously, the cases will be included into all the target stroke measures as well. For any sites, the concern was that we only included alteplase administrations in the coding instructions, so we didn't want to lose the volumes of those patients. We will have some more granular data within there that'll ask for maybe the specific reason on why you chose tenecteplase over alteplase, and this is purely for a data collection standpoint of us as these new guidelines come out. We need to get a good understanding of what's the practice out there in the United States and what are the reasons. The two reasons, obviously, that will be an option right now are patients with potential LVO, for EVT, and then the second would be mild stroke symptoms. So there'll be that, and then obviously throughout the tool we'll add some more granularity of if the patient's transferred into you now, rather than just saying they received alteplase or thrombolytic administration prior to arrival, it'll ask which agent was administered at that outside facility. All of this will transfer over into the report section, so you'll be able to run reports based on the agent given as well. So you could run just your tenecteplase patients, just your alteplase, obviously, arriving at your facility prior to or in your facility. So a lot of that stuff coming out in the very near future. It'll be later down the road this summer, but it's in the works right now.
Thank you, Jason. So I've also added the classification recommendations for level of evidence as a resource, so once you're reviewing the slides later. The next question we received is, if a physician documented etiology of the stroke is likely arthroembolic from the right ICA arteriosclerosis, what choice should I choose for etiology of stroke? So per the coding instructions, it says ischemic stroke etiology. There's one cause identified as the most likely etiology, select that one choice. And under large artery arteriosclerosis, it does reference going back to the ICA. So for that question, you would choose the large artery arteriosclerosis. I don't know, Jason, you're welcome to chime in if there's anything you want to add before I go to the next one.
No, I think you hit it. The big question comes up is that if it's thrombus, it's cardioembolism, right? But that's a separate option. It's not really coming from that section. So some of these vessel-to-vessel thrombus, you kind of have to fit what fits, or you have to choose what fits. And based on the description that was given here, this option one, the large artery, would be the most appropriate.
Thank you. Our next one is, if the CTA showed occluded distal right M2 branch, do I answer no to was a target lesion identified? So again, going back to the coding instructions, allowable values, yes, there was presence of a large vessel occlusion identified or visualized upon reviewing vascular imaging. And there's also a note saying a target lesion is referring to the proximal large vessel occlusion. So probably brings up the question of, because it says distal, not that since the person I did not talk to specifically, when I see distal, I would think that they're referring to the location within the M2, where the proximal is saying the closest lesion that you are seeing, the closest large vessel occlusion that you're seeing. Because in theory, that the proximal is going to block out anything past that for blood flow, unless there's collaterals there. So for this one, no, they would choose that, yes, there was a target lesion identified, and it would be the M2. Jason, if you have anything to add, you're welcome to. Otherwise, I will hand off to you so you could demonstrate the EMS picker.
All right. Yeah, I don't think I have anything to add to that. I mean, it's kind of, you know, the intention of the data element is to ask which vessel you see on the advanced imaging. So even if it's the distal portion of that, because I mean, it's not distal 2. If it's distal to the M2, then it could be the M3, but it's still considered a large vessel. But I think that's the reference of proximal large vessel occlusion just means the most proximal occlusion that you find on imaging. That would be the specific target lesion, even though there could be distal occlusions as well. Okay, so we'll go and let me share my screen. And it should be up. Ron, can you just let me know that you can see it?
Yes, sir.
All right. All right, everyone. I'm going to pull a presentation up. Many of you that attended ISC, if you were there, you know, you kind of, if you came by our booth, we had an ambulance out there on the exhibit floor. We were doing some presentations on both Wednesday and Thursday with some hands-on and some specific demos around our stroke system of care, the EMS layer, and then also the data connection that we're building with some of our large EPCR vendors. So if you've seen this, this is kind of an overview of that. I want to just, you know, take the opportunity to jump on these calls and really show you all what's coming. Some very exciting things in the near future that we've been working on for a long time. So just to like kind of start this conversation off, because it all ties in together, is that over the past 2 years or so, we've really been taking a strong look and a turn towards system of care development in stroke, with Stroke Mission Lifeline coming out. Obviously, the first Mission Lifeline EMS algorithm was a great success. Good use by that for our EMS partners around the country. And then obviously the new one was just released at ISC 20 this year. So that's like the centerpiece of the stroke system of care work that we're doing around stroke, kind of modeling it after our STEMI Mission Lifeline program that we've done for years within our other registries. So those historically, if you've ever had the EMS layer that was within the stroke tool, we had a certain set of data elements. When it just came out, we really didn't have many measures that really worked along with the data collection. So the uptake and the use of that form, and even the measures that subsequently came out kind of on a soft launch several years ago, just weren't utilized, and the form wasn't used as much as we would hope it would. So you know, coming from a pre-hospital background and data and quality improvement for EMS, you know, it was something really important to me that I wanted to build something that was both meaningful to the hospitals, easy to abstract, but also a powerful tool that would provide you with, you know, forms and data and reports to give to your EMS agencies, and also feedback to your transferring hospital facilities. So what we did was we through a staggered approach, the first thing we did was we revamped the entire EMS form. So if you haven't seen it in a while, it might be a good opportunity. You'll see some of it here. but you might want to relook at it. So what we did was we went through every data element on there, and we reworked them to make them meaningful. We designed the form so that it's designed in a patient flow, so from basically dispatch through the care and arrival at the hospital. There's 27 discrete elements included on the form. Within the layer also, we took those measures. There was originally about 7, and there was 9 if you had the cover detail later. We expanded those out to about 14 measures now. They include both EMS process, but also outcomes. Several of the measures that were currently just rate-based, we got feedback from the hospitals that said they weren't as useful as they would hope they would be. So what we did was we created distribution reports for each of those as well. So for stroke screening, as an example, you can not only see the rate in which it's being performed, but also you can see the numbers and the different types of stroke screenings that are being used by your EMS agencies or transferring the patients. We did that with time intervals. We gave you distributions, again, to make the reports more meaningful. So when you run them by individual EMS agency, you're giving them feedback that's useful and it's operational to that agency. The other thing that we're really super excited about was we added a new EMS feedback log. If you don't know now, within the form, if you have the EMS layer, there's a one-click button to turn on a PDF that actually it appears. You're able to take that PDF and email it to your EMS providers. It's a case-by-case, obviously, feedback tool, so it goes back to the providers that provided care, and it gives all kinds of outcome metrics. We'll show you that in a minute. The other is the EMS time tracker. It's just like the time tracker report that you all have used on the inpatient side. We've now expanded it out into the pre-hospital environment, so it includes things like first medical contact, arrival on scene time, all of those types of things. So now we're looking at first medical contact to IV alteplase or first medical contact to CT, rather than the door to metrics like we have before. And the last part, which was really revolutionary, was that we moved to a centralized EMS list within the PMT. There is no national EMS list. Every state has their own numbers. So what we did was we created a central list that works much like the NPI list that any of you might use within the PMT. So you choose your EMS agencies off of that. But the best part is that for states and regions, when they go back and run reports or they pull data, you can now compare EMS agencies or look at those EMS agencies across hospitals because they're using the same reference number for all. So here's the form. Again, I'm just briefly going to go through this. There's 27 elements in total. 8 of them are required. They're bold because they're used to operate one of those pre-hospital measures. So when you turn on the EMS layer, you automatically get all the measures included with it. The logic is turned on to complete the form when a patient arrives to your hospital by EMS or MSU. All the data elements are built in the coding instructions to the NEMSIS v3 standard. If you don't know, NEMSIS is the data standard for all EMS across the country. So eventually, whatever EPCR vendor they use, wherever it goes, it ultimately ends up into this NEMSIS data standard. That's where it goes to the national level. The state data registries in all 50 states, they all operate on the NEMSIS standard as well. So it's very easy for us, if we build our elements, build them out in a very uniform fashion. Here's the list of the measures that are all included. We're not going to go through these today. We are, Jeannie and I are planning another webinar soon, a national webinar, so you'll have some information about that. We'll go through the EMS layer in some detail, but also we're going to talk about the EMS algorithm. So if you want to see more about these, you can join that webinar. The EMS feedback log, I love this thing. So many hospitals have been reaching out to us throughout the years and saying they wish they had a way to provide the metrics and the time to EMS within the tool. What they were doing is, and many of you probably do this, is you have an Excel spreadsheet or you have a PowerPoint slide where you plug all these times and things in and then you email that to the hospital. Well, we built a form that's within the tool. This is the first edition of it. We're going to have new updates coming that are going to make it even better for you. But we also added a new data element at the bottom of the EMS form that allows you to put in specific, feedback to the provider, basically. So if you type in a message into that comment section, it will automatically, appear on the follow-up form. So you keep it documented in the PMT, but also you give that special message to the EMS provider. So, encouragement, but also you can include things that maybe aren't included on the feedback form if it's a special thing you all are working on. If it's a project of bypassing the ED and going to the CT, you can put that follow up and things in there as well. So here's a copy of the follow-up form. This is what comes out of the tool when you click print. It has system metrics, EMS metrics, and then also stroke center metrics. So all of the typical, arrival and whether the patient got an NIH score, whether the patient got IV alteplase and the timings and things. But also if you look up here in the EMS metrics, it expands it out to the pre-hospital setting. And then all of the pertinent times are here, and all the discharge diagnosis and treatments that the patient received are all included in here as well. The EMS time tracker comes out in a CSV file. You set the date range, you download it, and there it is. A lot of the cases, the time calculations are already done for you, but it's much like the time tracker report. If you've ever used that in the PMT, that's native within the case list. This is an export that goes to CSV, but all the other times are obviously to the right of this that I cut out, but it does expand into the hospital. So this is the part that, all of that I just showed you is available within the PMT right now in the EMS layer. One of the biggest hurdles that we've heard from users is obviously number one, the access to the ePCR to be able to, find the ePCR, the EMS record, and then you have to basically transpose and you have to look at the data in one window and then put it into our data fields. It's very time consuming. There's a lot of room for error because you're looking at one form and putting it into another. And also as a paramedic, I know that we're horrible at documentation, and a lot of those times it's very hard for the abstractor, if they're not familiar with the layout of the ePCR, to know exactly which data needs to go into which field on our side, because there can be multiples and then things. So with all of that in mind, we set out to work with some large ePCR vendors to find a way to push data more easily packaged in that NEMSIS standard, and then be basically digested by the PMT to populate the form in which that you're working in. So this is the normal workflow that you work within if you do abstract. So you start abstracting the case, you realize the patient is EMS, you'll have to log into somewhere to find that ePCR, and then what you'll do is you'll find the record, you'll grab the data in, you have to manually enter it in, but obviously there's a lot of room for improvement there. There's a lot of room for error as well. So the two vendors that we're currently working with that are compatible vendors are First Watch, who's a data aggregate service. Some of your agencies may use that to push their data from their ePCR service into First Watch so that they can run analytics and they can combine it with other data. Also, ImageTrend is the other vendor, in which many of you may know them. They provide an EMS ePCR solution, but then they also house a database solution, which is Hospital Hub. So when those ePCRs are completed, it gets pushed up the Hospital Hub, and that's where a lot of hospitals access those ePCRs to look at those EMS records. You can do the same thing with First Watch. So some of your EMS agencies may use one or the other. So the way that this workflow will work in the future is that you'll identify the patient as the EMS. So you've created a record within Give It the Guidelines. And now what you would do is you would log into one of those portals. You would log into either First Watch or Hospital Hub, and you would search for that patient in an interface that we've helped create with those vendors. You'd find that record, and then there'd be a new option for you to click Get With The Guidelines, put the patient ID and Get With The Guidelines, and you would then push that record all packaged up over into your PMT environment. So you'll not have to look at one screen and then the other. Basically, you could go in and queue and find all of your EMS records and then push them all over to Get With The Guidelines, and then you'll match them on the PMT side. I'm going to show you that here in a second. So I don't have the access to the First Watch or the ImageTrend side. We didn't have them involved in this call, but as I described, if you've ever been into Hospital Hub, you search patients by name, date of birth, however you want to do that. You would only see records, obviously, that were transported to your facility. So once you find a record, there will be a new option that's down in the corner, and you click on that and enter the Get With The Guidelines patient ID. So what I'm going to show you here in our EMS demo is what you'll see in the future when this is 100% out of testing and we're ready to start enrolling other facilities. So I created a number of records in here. This is all dummy data, so I'm going to go into this record here, and it's EMS 803. So this would be you as an abstractor, you abstracted this entire case. And if you look through here, all of the inpatient data has been abstracted. I'll look here and just so you can see my errors. But as I go through, you'll see that the patient arrived by EMS, so that's what activated the Special Initiatives tab. And if I go into it, you'll see that all of the data is blank. So this is when I would have already gone into First Watch or Image Trend, and I've pushed this record over onto my side. So it should be waiting for me here when I log into my PMT account. So if you look up here at the top, we have a new data element you've never seen before. It's called an EPCR Patient Finder, and this is what's included in that new EMS layer for the uploader. So all of my records that I've pushed over from Image Trend or First Watch or any of my EMS agencies, when I click on this link now, I'll get a list of all of these records that I've just pushed over. You see I have a number of them, a lot of different EMS agencies, some from First Watch, some from Image Trend. But because I'm working in EMS 803, the record, EMS 803, because I typed in the Get With The Guidelines ID when I sent them over from First Watch and Image Trend, they're here waiting, and they already have the patient ID matching. So any patient ID that matches the one I'm working on, it will float to the top. If you, by accident, forgot to type in the 3, so it actually says EMS 80, I could turn on the filter. I could search it by the EMS agency. I could search it by, the closest number that I think it might be, and I could just confirm that that is the one I want and click import. So the numbers don't have to 100% match, but obviously when you push it over, if it does match, it will float to the top, so it's easy for you to find. So either way, here's the case. I know this is it. This is National EMS Incorporated, EMS 803. That's the run number. This is the date in which this call happened, so I know this is my case. I'll click import, and I'll get a single quality check. It just says, I'm just confirming this is the case, this is the date and time. And if I click OK, if you look at the fields here, it just auto-populates now all of those data elements. What it's done is it's taken the EPCR record that's come over in that NEMSIS standard, and we've mapped it one-to-one to our specific data elements because they meet the V3 standard. And then it just populates the times, populates the data elements if it's available in the EPCR. The bulk of these, as I said, we're in live testing right now with certain sites. The success coming out of the EPCR is extremely high. There may be certain elements that, either your EMS agency, doesn't have very good quality control of their data coming out, but that's a teachable. So that's a teachable and a quality improvement thing that you can do with that EMS agency. So for example, if you keep importing these records and you see that stroke screen is never documented, well, that means that in their EPCR, they don't have a proper validation in place to require the provider to enter a stroke screen before they sign and close that record. Coming from that side of setting these up and working in EMS quality improvement, we used to do that all the time. If there was something important we wanted to make sure was collected, you could build a rule in just like you can in your EMR to require that collection. So that back and forth and that communication with the agency can get a lot of these things sorted out. But what we found so far with the agencies we're testing is that the bulk of the data elements, and this was by design, are already required data elements for the national EMS system. So they have to submit this for every call, which is all the times, for example, and whether it's suspected stroke, all of those. So anyways, all the data came over. Now, if something didn't come over, it would either just be blank, or if it came over and it was just, let's say they just documented a date, it could be there, or if there's something that's missing. So like, let's say none of this stuff came over of like what was provided in the call. If it's in a narrative somewhere, you can still select these by hand. You could change this data. So it doesn't lock you out just because you import it in. It's really just a quick way for you to load all these data elements in here. So you're pre-populating everything, and it should cut down, a tremendous amount of time per record, just pulling these records in. So with that, you would mark it complete, and you just save, and it would save the data in. I'm not going to save this one because it's a demo, but for example, if I kept pushing records over, I'm going to come to this next one, EMS 796. I could open it up. This one's already abstracted as well. I know I already went into Image Trend and pushed this over to me, so I could just go right to my Special Initiatives tab, click my Patient Finder, and this record 796 is going to float to the top now. I could grab Import, and that all that data came in as well. I could then mark this one saved and go back to my patient grid and so on. It's just a quick way for you to populate all of those fields. So let me go back to the slide deck here. You know, where we are right now with the project is that we are, like I said, in the final stages of testing. We've already done our internal testing, and the connections with both of those vendors is working as designed. We're now doing live testing at certain sites across the country, and we're hopeful within the next several months that we're going to be able to offer this and start offering and enrolling sites into this. But I wanted to, you know, Ron wanted me to get on to give you all a good sneak peek, to show this to you, to make sure it's on your radar, that this is coming. It is a thing. It is going to be available in the very near future, and your local folks will be, you know, driving that onboarding and everything to you. So Ron, I'm going to stop just because we only got 5 minutes. I want to make sure there's no questions or anything for you.
Thank you, Jason. I appreciate it. So one of the questions that was typed in is, when will the changes take place? Are patients discharged in 2019 affected by the discharge on intensive statin change? And are patients discharged in 2020 affected by the discharge on intensive statin change? So for the new award metrics, the discharge on intensive statin and the arrive by 3, treat by 4.5 hours, those are moving to achievement measures for the 2020 data. So the 2019 data, the one that we're reviewing data now and getting ready to do all the award announcements later this year, will be off of the 2019 data with the measures that have always been there: arrive by 2, treat by 3, discharge on statin, or those achievement measures. 2020 data, so the data that's being entered now and the data that we will then be doing your award review in 2021, will then be looking at the intensive statin and arrive by 3, treat by 4.5 as the achievement measures that will have to be at 85% or better. The quality metrics will be losing 2, so instead of having 5 out of 8, you'll have to have 5 out of the 6 at 75%. The next question that I see was saying something similar. Jason or Jeannie, I'll leave this one to you. It is, what are large vessels considered distal LVO?
I'm sorry, I can't see the question, but I'm assuming that means what are distal? What are distal vessels? So anything beyond the M2. And there are doctors who will go after M3 plots, but they're much more difficult to get to. So anything beyond M2 would be considered distal, a distal vessel.
Thank you, Jeannie. I know there's a couple other questions that are still pending, but due to it being at the end of time, I just wanted to say thank you all. If you have any further questions, please feel free to reach out to your Quality and Systems Improvement team out here in the Western States. The questions that did come in during the presentation that weren't answered, we'll make sure we get answers and send those back to you. So thank you, everyone. Have a wonderful day. And that concludes our presentation for today.